Welcome to all. Thank you all for joining.
Yes, hello, and thank you for joining today's webinar on today, the last day of One Health Awareness Month. Today's webinar is titled One Health High-Level Expert Panel, Practical Applications in One Health Governance, which we at CABI's One Health Knowledge Bank are delighted to bring you in association with OHHLEP. We would also like to welcome our speakers, Dr. Margaret Keitzer and Dr. Nitish Debnath, along with our panel, Abigail Buchanan-Wright from OHHLEP, members of the Quadripartite, and Lisa Crump, Deputy Editor of CABI's One Health Cases. I'm Georgina Grell. I'm publisher for CABI's Animal Health portfolio. I also look after CABI's One Health Knowledge Bank with my colleague Frida, who is Associate Publisher focused on public health. The One Health Knowledge Bank is part of CABI's integrated One Health resources, which also includes One Health Cases, which provides real-world examples of One Health projects, and One Health Journal, and CABI's One Health Journal, a truly transdisciplinary open access publication emphasizing the interconnectedness of humans, animals, plants, ecosystems, and their shared environment. And now I'd like to introduce my colleague, Frida.
Thank you, Georgina. For those who don't know much about CABI, it's a vast organization, and our main operations is international development. So we're not for profit organization focused on international development, and we're supported by a publishing division, which we work in, and a scientific research base, which does amazing things. I mean, I've visited and there's lots of amazing things happening there. So for over 100 years, CABI has been applying scientific expertise to solve problems in agriculture and the environment. So all the profits from our publishing arm support this international development around the world, helping to improve lives worldwide. There's amazing things they're doing with smallholder farmers to produce crops long term. And many of these projects align with several sustainable development goals. Our publishing department offers a wide range of products as well beyond One Health, including various searchable collections and databases, one of which I work on called Global Health, which also has One Health content, so feel free to also explore that. Today's webinar explores two cases that are produced by OHHLEP. These form part of a special issue in One Health Cases, and the remaining case in that special issue will be highlighted in another webinar, so keep your eyes peeled because there will be more coming. And now I'm happy to hand over to Dr. Lisa Crump.
Well, hi again. I'm really delighted to welcome all of you today. We're really excited about One Health Cases, which fill a quite important gap in the education aspect on integrated approaches. And these are an expanding collection of online case studies. And the uniqueness is that they focus on practical actions. So cases are real-life examples of how a One Health approach has been implemented. And so they highlight both the successes and the challenges of operationalizing multi-sectoral collaborations. And we really feel that students and practitioners need to hear about what doesn't work as well in order to catalyze these meaningful discussions and explore solutions. So our aim for every case is to include two what we call must-haves, that they should clearly describe the extra value of utilizing an integrated approach. And of course, working across sectors is hard. And so we want the case to tell the readers why it's worth the effort to integrate those approaches. And secondly, every case should utilize a transdisciplinary method. And for us, that means incorporating both academic and non-academic communities, because each one of these brings different but really quite essential knowledge into the process. And without this connection, we'll never solve these wicked problems that are confronting our world in so many different specters. And so the editors and the team at CABI are hopeful that One Health approaches effectively applied and broadly and carefully documented, and equally importantly, widely disseminated, will be able to make a significant difference. So to that end, thanks for joining today's webinar. I hope everyone finds it engaging, and I'm going to hand the microphone over to Abby, who will introduce the quadripartite on behalf of WHO. It's yours, Abby.
Great, thank you. Oh, thanks, Lisa. Thanks, Georgina, and thank you, Freda. I'm Abigail Wright from WHO, and I'm responsible for the Secretariat of the One Health High-Level Expert Panel, which is the scientific and strategic advisory panel to the quadripartite, and it's currently hosted by WHO. So thanks so much to CABI for hosting this webinar, and to our OHHLEP colleagues, Nitish, and to Margaret and her co-authors for agreeing to present their cases. I'd also like to introduce my colleagues from the quadripartite who are present and will be available to engage in the discussion following the presentations. So from the Food and Agriculture Organization of the UN, we have Barbara Hessler and Feyrouz Larfaoui, and from the UN Program on Environment, Nadia Munsterman, from the World Organization for Animal Health, Chadia Wanous, and I will represent WHO. So I'm going to give a brief overview of the quadripartite collaboration on One Health and the One Health high-level expert panel, and I'll go through it quickly so we can get directly to the cases. Next slide, please. The tripartite collaboration comprising FAO, WHO, and WOHA has been active for more than a decade, although each organization has been focused on critical One Health engagement within their institutions and with their member states for even longer. In 2021, UNEP joined to form the quadripartite, bringing a stronger focus on the environmental dimensions of health. Since 2018, the collaboration has prioritized strengthening of health systems, addressing specific technical areas such as zoonotic diseases and tackling AMR, also food safety, as key pillars of the One Health approach, but also at the interface and addressing the cross-sectoral elements such as integrated surveillance, governance and policies, emergency preparedness and response. And in 2022, the quadripartite launched the One Health Joint Plan of Action, which by now most One Health practitioners are pretty familiar with. At both the global and regional levels, the quadripartite coordination has a multi-tier mechanism to reach directly to country counterparts. Next slide, please. In 2023, the principals of the quadripartite organization signed a call to action to confirm the ongoing commitment of FAO, UNEP, WHO, and WOHA to continue collaborating on One Health under the framework of the One Health Joint Plan of Action. Next slide, please. The quadripartite has a secretariat that rotates every year across the 4 organizations. It's currently sitting at WOHA, and this secretariat organizes collaboration and engagement across the 4 institutions. The 4 priority areas for collaboration are to promote and support the implementation of the One Health Joint Plan of Action at the country level, to generate and share science and evidence for the implementation of the One Health approach, to maintain the political engagement and advocacy for One Health at all levels, and to leverage sustained investment for One Health, including for the quadripartite secretariat. Next slide, please. The One Health high-level expert panel was established in 2021 as an advisory panel to the quadripartite to support their provision of evidence-based scientific and policy advice. The first term of OHHLEP was completed at the end of 2023 with key deliverables achieved, including the One Health definition, the theory of change, the inventory of One Health tools. And the second term began in April 2024 with a redefined terms of reference, really focusing on supporting the implementation of the One Health Joint Plan of Action, and a recomposed panel of 29 members with broader expertise, including social and behavioral sciences, economics, policy, ethics, and some broader expertise in the environment, as well as a youth candidate. So some of the work that OHHLEP is doing now, sorry, can you just go back one? Yeah, some of the work that OHHLEP is doing now includes a look into the enablers and barriers to implementing the One Health Joint Plan of Action and the One Health approach more broadly. Another area they're working on is to support the development of further guidance using the One Health tools and a taxonomy of international legal and policy instruments that have a bearing on implementing the One Health approach. Next slide. So I'm going to go back to the OHHLEP deliverables from term 1 because that's where the work on case studies began. And term 1 during term 1 of OHHLEP, which began during COVID, was a very productive term. And as I mentioned earlier, it really set the foundation for term 2 with the definition theory of change, but also work on an inventory of tools, an opinion on the prevention of zoonotic spillover, a One Health approach to highly pathogenic avian influenza, H5N1, and a paper on integrated surveillance. And they also started to work on the case studies, which is kind of rolled into term 2. Next slide, please. So one of the most important deliverables that OHHLEP worked on during this period were these case studies. And it kind of evolved over time, but the thinking was that there exists a huge gap in the documentation of real-world implementation cases that contribute to learning, and that the sharing of experience of practitioners in a variety of settings and covering different aspects of One Health was highly desirable. So we wanted to ensure a level of peer review, and the CABI format for cases cover many of the bases that OHLEP and quadripartite sought to address. For example, description of what makes a case a One Health case, the forward-looking view on sustainability, as well as learning. So the quadripartite was very, very grateful to CABI to make these cases open access and to devote a special issue to OHLEP contributions. 5 OHLEP members submitted cases to CABI, and they're mostly out now, as Freda was explaining. And today we'll have 2 presenters to share their cases, Margaret Kaitza, who served on OHLEP during the first term, as well as her co-authors, and Nitish Debnath, who has served on the panel in term 1 and term 2. So I'd like to thank CABI for hosting this webinar and inviting the quadripartite and OHLEP to share their experiences. So I'll turn the floor back to Lisa. Thanks.
Thanks a lot, Abby. And I think without any further ado, we'll go ahead and start with you, Margaret, with your case, and we'll get your slides up and let you go ahead. Thanks for keeping to time, everybody. That was amazing.
I apologize, my video I'm having trouble with my video, so I'll just go ahead and present.
No problem.
Okay. So thank you again, everyone. I'm going to present on the case of the Coordinating Office for the Control of Trypanosomiasis, now trypanosomosis, in Uganda, abbreviated as COC2, which was the secretariat that was set up for the Uganda Trypanosomiasis Control Council, which was put in place by an act of parliament of Uganda in 1992, specifically for the control of trypanosomiasis. And I would like to appreciate my colleagues, Dr. Zuba Rose, who was the vice chair of UTCC, and Dr. Waiswa Charles, who was the director of COC2 from 2013 to 2022. Thank you. Next slide, please. So that's the outline of my presentation, the background, the objectives of COC2, the activities and the achievements and the challenges. Next, please. I just wanted to show this slide that there are so many zoonotic diseases in Uganda that have been identified. I'm sure there are more than that. And trypanosomiasis was just one of them. Next, please. And Uganda, like many other countries, has done they have prioritized the zoonotic diseases, which ones to work on first, and ranked them with the aid of agencies like the CDC and the USAID, plus the national stakeholders. And African trypanosomiasis that I'm going to talk about is ranked as number 5 of the 7 on the list, with anthrax as number 1. And most of these diseases, we have outbreaks occurring almost every year. Next, please. So African trypanosomiasis has been on the continent since the 1900s, and all this time we've been trying to control the disease. And I didn't think I would see it controlled, but I was pleasantly surprised in 2020 when the human African trypanosomiasis cases, or HAT, or sleeping sickness, were brought to 0. And congratulations to the COC2 for that success. And the animal African trypanosomiasis, or Nagana, we still have cases of that. And we have more than 37 countries in sub-Saharan Africa with cases of African trypanosomiasis, affecting so many people, up to 50,000 or 70,000 per year. And the 2 main species are Trypanosoma brucei gambiense, shown there in yellow, and then the Trypanosoma brucei rhodensiense, shown in green. And the 2 have a different epidemiology, with the T. brucei gambiense causing a chronic form of the disease, and the other one causing the acute form. The vector is the sassafly, so the control efforts are usually geared at both the trypanosomes and then the sassaflies. Next, please. And Uganda, I didn't, if you can go back, sorry, I forgot to mention that Uganda is unique because it has the two forms of the disease. So most of the efforts have been to try and separate those two so they don't merge to complicate the control. Next, please. Next slide. This just summarizes the life cycle showing how the parasite multiplies in humans and also in the saxifrage, making it very difficult to control. In the interest of time, I'll move on to the next slide, which summarizes the objectives of WCOG2, what it was set up to do, and it was to act as a secretariat to the Uganda Trypanosomiasis Control Council, and to coordinate all the government departments, the donors, the non-government organizations that were involved in the SESE and the trypanosomiasis research, prevention, and control in Uganda, to monitor the project inputs, the implementation, collect and disseminate the information to the relevant government departments, organize the seminars, the workshops, the conferences, the manpower development or capacity development, and coordinate all the national, regional, and international agencies that were involved. And the next slide will show us those agencies. So we had, these are some of the agencies that were involved, development partners, WHO, FAO, those are the two members of the quadripartite that participated, but we have other agencies as well. If we can show the next slide, has a list. The next slide has a list of other international development partners that were involved. The African Union, especially the Inter-African Bureau for Animal Resources, or IBA, and the International Livestock Research Institute, the International Center for Insect Physiology and Ecology, ICIPE, and the Swiss Tropical Institute and Center for Veterinary Tropical Medicine, that's the University of Edinburgh. So we had other local universities as well, like Makerere University and others involved. So next, please. So COC2 was to coordinate all these agencies. These are the government of Uganda ministries and agencies that were involved. I have listed 7 of them there. These were the key ministries: Ministry of Agriculture, Animal Industry, Ministry of Health, Ministry of Tourism, Trade and Industry. I mentioned those first because they are members of the National One Health, the National One Health platform. But we have the Ministry of Finance also involved, which was very important to make sure that the resources were there from the government contributing to the efforts. Ministry of Land, Water and Environment, Ministry of Foreign Affairs to coordinate all those development partners. Then you have the national agencies, the National Research Organization, and the academic institutions like Makerere University were all involved. So COC2 was to coordinate all these. Next slide, please.
Margaret, may I just another 2 minutes, and then we do want to leave a little bit of time for questions. So if you can just give us, I'm sorry, it's disadvantaging you to only give you such a short time, but if you could, that would be really helpful. Thanks.
If we can move fast, because these are just pictures showing the activities actually that COC2 did. Yeah, training, technical people, the community, giving accountability to the government agencies. Let's move on. I think we are moving backwards. Front. These are the government agencies, field days, learning about the activities that COC2 was doing. Next, please. They had an assessment and operational plan. Next. Those are the activities. Those are known, I think, how to control trypanosomiasis. Next slide. Those are the districts they were focusing on, which actually are also border districts that separate the T. gambiense up and then the rhodensiense down. Next. And that's just the main piece of information showing how the disease was brought down from between 1992 when the agency was set up to 1920. This shows up to 2019, but 2020 we didn't have any more cases. And those are lessons learned which we can go on when during the question and answer session. So we can move on to the next one. why COC2 was a One Health best practice, just to show that the political will, the last slide there, and the legal framework was very, very important to make sure that it was successful. And also they addressed issues right from the community, subnational, national, and regional level, and global level as well, plus the coordination outside all those ministries. I think those were the factors why this was a best case scenario and was successful. Next. The challenges that after we successfully control the heart, now we, instead of continuing to work on the list of zoonosis I showed you at the beginning, we are now not contributing funds anymore to the COC2, and COC2 is not in existence anymore. That's the sad part, the challenge. Next. Yeah. I wish to acknowledge all those agencies that contributed to this case study, and CABI for publishing it. Thank you so much.
Thank you very much, Margaret, for that quick flyover. And it is in the chat, there's a link to the whole case for those of you that haven't had a chance to read it. I'd like to open up the floor for a few questions. Does someone have a question for Dr. Kaitsa? I'm not sure I can see the questions, Frida. So if I'm doing something wrong.
Sorry, there aren't any questions in the Q&A at the moment. If the panelists have questions.
Okay. Well, if somebody has a question, feel free to jump in. Otherwise, I'll just start off with one while you're thinking about it. We have about 5 minutes for discussions, and then we're going to jump to the next case, and we'll circle back at the end with any additional time. But one question that I had for you, Margaret, was I know that the COC2 set up this independent coordinating office, and then because it was deemed a success, I understand that the office was disbanded. And so my question was that, you know, that's interesting, but I just wonder if, you know, if there has been a structural change since then, or what your advice would be to, you know, towards the end of sustaining that success with that office if it's disbanded.
I was hoping my colleagues would be on the call to help me answer that question, but I think it just goes to the fact that the sustainability bit was not included in the initial planning. I think if it had been included, then we would have moved on to, first of all, even the animal trypanosomiasis, animal African trypanosomiasis is still there. So the cases were reduced and reduced in humans, in heart, but we still have the cases in the animals. So the fact that it was disbanded is a challenge, because I was checking in to see with the people who are in the field whether we are having cases, because surveillance is still ongoing, whether the cases in animals which had been reduced also are now beginning to go up. So so that's a challenge. I think we should have included that in the sustainability to make sure that if we are done with the African trypanosomiasis, then we can start tackling any one of those, even 7 priority zoonoses or the long list of 50 or more. So it's a challenge. That is a challenge.
Yeah. Well, that's one of the questions in the chat from a participant is there anything you could suggest that might have helped COC2 to be sustained over time? And you've alluded to government prioritizing, you know, financial resources. Are there other things that come to mind that were particularly obstacles for the sustainability?
I think looking in from outside is very difficult for me to suggest ways of influencing how resources are distributed. So I think it is something to do with maybe lobbying or the national platform. The national platform, which is comprised of many of the ministries which were part of this, prioritizing this and making sure that the resources are there for the COC2 or this coordinating office.
I guess that's not a new problem. Other areas have had that. That relates to another question that's asked in the chat, which was, how did the experiences of COC2 contribute to further coordination in Uganda? And I think yeah, you've as well alluded to that. But do you have any specific complement to add that you could say, well, COC2 really contributed to improve coordination between that One Health actors?
One of the challenges, speaking to some of the members of COC2, was excuse me, was the silo mentality.
Yeah.
Excuse me. The silo mentality is something that continued even during the process, during that time. So maybe no wonder that the coordinating office which was trying to break down those silos.
Yeah, I can imagine that's the case. And I think also interestingly, I mean, this started in 1992. That was a long time ago. So hopefully things progress. Thank you so much for the interesting case. I'm going to move on to our second case, just trying to keep us on time. And certainly, I'm sorry, there are a couple more questions in the chat that we haven't answered. If you want to try and type answers to those, Margaret, you can do that. And I'm going to turn the floor over to Nitish for our case number 2, which is coming from Bangladesh. Nitish, the floor is yours.
Thank you. Thank you very much. Ladies and gentlemen, wherever you are, and good evening, good afternoon, good morning. And as you can see, I will be sharing some of our experience of One Health governance in Bangladesh. And what I will be talking, basically, I will be answering 3 questions. These are the 3 questions that in front of all of you. When we started One Health journey in 2008, we had a very strong brainstorming. The main question to us, why One Health for Bangladesh? And that is what I will be going to share with you. And then it was really developed very organically. How did you conceive that idea? I will share with you. Now what is being done, what is our way forward. Next slide, please. And if you see the next slide, that the question that I was answering to all of you, look at this slide. This is what, we discussed during that time. Bangladesh is a very small country, only 56,000 square mile area, but the population-wise, it is 8th of the global population, 8th number of the country. That is, we have almost 170 million people. It is a very highly densely populated country. Per square mile, I think it is almost 1,200 people in a 1 square mile area, people lives there. This is one important reason. Also, this country has been recognized already as a hotspot for EIDs, including Nipah, avian influenza, swine flu, Zika, all these things we faced and we have been facing. This is number 2 that during that time we discussed, and also the food security and food safety vulnerability, because we are very dependent on our own production, particularly in the agriculture sector, and also recently the intensification of the animal production system, in particular in the poultry area. Other than that, there are a lot of environmental vulnerabilities, including severe water shortage in the drought, close proximity between animals and humans, fragile ecology, and wildlife habitat destruction. All those reasons why we really conceived the One Idea when we started the journey, those are the reasons why we convinced our colleagues, participants that let's go for One Health. Next slide, please. Now, when we really go to the One Health, basically, it is an initiative. Look at these 5 points. Well, the 2 important diseases basically inspire us. We had an avian influenza in 2007, and Nipah viral infection during 2003 to 2005, several number of outbreaks in our country. Those were the two main diseases that inspired us. It is not only what we thought, it's not only avian influenza and Nipah, maybe many more will come in the future. Let's go for coordinated work culture and how we can coordinate each other. And during that time in 2008, we organized a One Health conference. It's sort of international conference like in Chittagong Veterinary and Animal Science University. And we moved forward with a sort of civil society platform, which is open for all any health workers, including animal health, human health, environmental health, even social science and other people. And that is how we started our journey in 2008. And between 2008 and 2012, we did a lot of advocacy, particularly targeting the government to gain their support, different institutions, different professions. And finally, in 2012, we were able to develop a national strategic framework for One Health. And we did some strong advocacy with the government to approve it. And finally, in 2016 and 2015, three ministries approved this proposal: Ministry of Health and Family Welfare, Ministry of Fisheries and Livestock, and Ministry of Environment and Forest. All those three ministries endorsed these things, and they made commitment to go for to implementation of these framework and action plan. And that's how we developed a One Health Secretariat, a three-tier coordination mechanism. One is the interministerial One Health Steering Committee, another is the National Coordination Advisory Committee, and then One Health Secretariat. One Health Secretariat is more of a basic, functionality. Otherwise, other committees are time to time sitting together, advising, overseeing activities. Next slide, please. And from that on, we have been really strongly pursuing our One Health activities. Please go on next. And next, you'll have to go quite a good number of next. And this is One Health Secretariat, these are the functions, 6 major functions here: policy, advocacy, monitoring, facilitate One Health capacity building, priority research, multi-sectoral coordination. Those are the One Health Secretariat. From then on, One Health Secretariat and One Health Bangladesh have been working together. That is the very important collaborative approach that we are making. Civil society and government platform are working together. Next slide, please. And since then, from 2007 next slide, please. And look at this slide. From 2007 to 2020, go on, you can go ahead. A lot of activities we have undertaken during this period of time, including outbreak investigations, international consultation, organizing conferences, prioritization of the zoonotic diseases, and many more activities. And initially we started to organize yearly conference, then we go biannually in conference. And during COVID, this 2020, next slide, and you will see that activities and what we did in the COVID time. Our laboratories are working, collaborating. Human health, animal health laboratories are working together for detecting the cases, and these were very important there. And you will see the 6 important stream of activities that we are focusing during all this period. That is how developed: coordination, outbreak investigation, surveillance, laboratory networking, One Health capacity building, multidisciplinary research, conference, seminars, and dialogue. Next slide, please. And if you see that, this is how we have been moving. But COVID gave a very important lesson. And then after COVID, we have been revising our strategic framework. And in addition to what we have been doing, and 6 important areas we focus that we need to expand our coordination mechanism from nation to the Upazila level, what we call the community level, development and deployment skill of workforce, and also strengthening the pandemic prevention preparedness response plan, protection or restoration ecosystem, and disciplinary research, and aligning with our joint plan of action of the quadripartite. These are the main, newer focuses in addition to what we used to do in the past in our strategic framework. Next slide, please. If you see our extended now, we have been working to our coordination mechanism in a very different way. Look at that. And if you see that one, In the past, we used to be in the national level, interministerial level, sectoral technical committee, One Health Secretariat. Now we are expanding our coordination. 4 more strata we have developed. One, we are engaging politicians in the national technical advisory at the minister level, and then other 3 level and One Health coordination at the division. Bangladesh is divided into 8 divisions. In each division, we are trying to develop a One Health hub and district and OHHLEP. And also we included more sectors like food sector and agriculture more effectively, and others were there. Next slide, please. If you go to the next slide, you will see that how.
Nitish,
Yeah.
I'm sorry, I'm gonna say the
Yes,
same
I
thing,
will be
but
spending by 2 minutes. Yes.
perfect. Thank you
Yes.
so much. Sorry.
Yes. No problem. And this is our extended, new core group of activities and support and extend. Next slide, please. And if you go to the next slide, please, you will see, go ahead, and we will see that our activities now, in the division level, I have already mentioned, and the community level, we have doing our activities. Next slide, please. And you will see that we are also activities now, a sort of other networks, networks, One Health Bangladesh, AMR network, universities teachers network, young helper network. We're trying to develop a Olympiad and going to do the One Health community level. Next slide, please. With all those activities, what we are really focusing on, that one broad forum we have created. Every 2 years, we ask everybody to come from different disciplines to participate in the conference. Look at the structure, We started it in 2008. In 2023, we had the last conference, and it was, a sort of conference with more than 1,000 people, 3 days conference. Next slide, please. And if you see the next slide, that you will see that we are basically approaching, this is the sports step model for One Health activities in Bangladesh, developing ownership, partnership, framework of action, and continuous working and sharing. With these things, I think I will thank you all, and this is what we published in CABI. Thank you very much for giving this opportunity to share Bangladesh case. A lot of challenges, but I will talk when the questions come. Thank you.
Thank you so much. And I apologize again to both of you for such a compressed time frame, but we really wanted to just have this high level flyover of your case, and we've posted in the chat where people can read the whole case. But I'd like to open the floor up now to questions. You can type them into the Q&A, or can they also unmute their microphones? I'm not sure, Georgina, if that's possible for people to do that. I don't see. Is it? Can they raise their hand, or is it better if they type into the chat box?
They will have to type into the Q&A, please.
Okay, so type your questions into the Q&A, and then we'll try and answer them. While you're having a minute to type your questions in, then I'll just well, actually, we have a first question, I guess, and that is coming. Where is the One Health platform based in Bangladesh?
It is based in Dhaka. The central for platforms is based in Dhaka, because the government is in the One Health Secretariat is located in one institute of public health, what we call IDCR, Institute of Epidemiology and Disease Control Research. And in the same building, we have a One Health Bangladesh office as well. And other platforms, they are working on their own way. And those who are contributing and taking initiative from their own, but we meet every 2 years in one platform. And that platform is created jointly by the government, One Health Secretariat, and One Health Bangladesh. The conference that we organized every 2 years, it is basically an initiative of the government as well as the civil society platform, but it is open for other partners as well to contribute. So mainly you can see it is located in Dhaka, but PECO colleagues are, in the periphery, they are also very active and doing activities.
And does the conference move from place to place, or is it as
not
well
yet.
central?
No, initially it started in Chittagong, and the first 3 years or 4 years, it was all in Chittagong. Now it moved to Dhaka. it is always good to have some central one, a fixed one. That is what we are doing now at the moment. But I must mention to this, there are a lot of other seminars, conferences, initiative at the peripheral level, like universities, Chittagong, Dhaka, Mymensingh, and some other institutions. They also take initiative developing, organizing some dialogue, seminar, conferences as well is the name of One Health. But this one is the central one, open to all. We organize in every 2 years.
Yeah, yeah. And another question which comes up, it's a bit related, but is has the initiative been formalized at the local level? How does that look?
Yes, the local level one, just like pointed out in my presentation there, the divisional, hub. Very recently, that is the new development in our coordination mechanism. Government partners all agreed that yes, we'll go for the divisional One Health hub. And we have also identified the activities. The most important priority is the AMR containment. In all, there are lab network in all those 8 divisions. We are, bringing them together and then gradually, put up other activities, including outbreak investigation, rapid response team. All those activities are identified. Yes, government formally endorse these things, and we are collaborating. Development partners are engaged in the development of this platform. And recently, One Health Portia, we got the support from the UKRI. With the support of them, we have developed a sort of small model to work at the community level, engaging, the different type of health providers, animal health providers, human health providers at a very grassroots level. A sort of model we have developed. Now we are trying to multiply it in other 7 or 6 districts, in a very community level. This is how we are going. It is moving great. Yes.
Yeah. And how does that play out in terms of issues that may affect one region but not another? Does that give the flexibility that's needed to be responsive?
Yes, it is a flexibility. It is not, we are not prohibiting anybody to take that initiative. But as you said, anybody can take that initiative to develop their own platform, because the National Strategy Framework reflected that one. And also in the National Steering Committee has decided to develop this, district level, divisional level, and what we call the lowest OHHLEP is the blocks level. And that is the directives has already been decided at the National Steering Committee. So some are working at the moment, progressing, others are going slow. But we believe, because it is just 2 years that we have decided, we'll go to the down to the national level.
Yeah.
Thank you.
And another question that comes through is wondering a bit about how the financing is worked out. Does the platform have its own budget, or is budget allocated per program area individually? I think
that is an important question. There are 3 sources of financing. One, of course, for One Health Secretariat, Ministry of Health and Family Welfare has put a sort of budget, and that is the government budget, directly hardcore government budget. This is one thing. There are quite a good number of development partners who are also supporting One Health initiative. That includes, US CDC, USAID, and also Fleming Fund, SIVA, all those, they are, and we do coordinate with them as well in terms of implementing. Some are focusing mostly on the AMR, some are focusing quantified as well, Fleming, some are focusing on avian influenza, some on Nipah. All those things are going on in different sector. But what is important there, that engage the different sectors, both the this is what is the facilitation from the One Health Bangladesh. We promote, we actively engage different professional people to get engaged and to make it easier so that coordination works well. And those are the financing sources. We are exploring more, and we are advocating to the government to really put more money for One Health.
Yeah, thank you so much. Just to let the participants know, we can circle back to general questions for either presenter if you like now. We have about 10 more minutes, and there are some more questions in the chat. I'll just work my way through them. But if you have more general questions, not particularly aimed at the Bangladesh case, we'd be happy to entertain those as well. So I'm going to go back first to some of the earlier ones that came in, if I can. And this is a question about COC2 for you, Margaret. The question is, did those experiences contribute to further development coordination activities, integrated approaches in Uganda? And are there possibly some topics, individual topics that could be, looked at in a sort of broader coverage, multiple challenge perspective?
Actually, I'm glad that Dr. Charles Waiswa is on, and he was the director of COC2 for some time. I'm not sure whether he's able to speak, but he might have a better answer than what I could give. But
Is that possible, Georgina, for him to be unmuted?
Yes, I'm able. I can unmute. Greetings, everyone, and thank you for this high-level engagement. Yes, it is correct. The impact of the coordination on so many of the sectors to work like in the model was duplicated, and whenever the challenges came, there was something to borrow on how professionals come together. And that has gone on in Ebola, it has gone on in all the other avian influenza, people coming together and growing professionals from different aspects. It even went down to the decentralized districts. Uganda has about 150 districts, and you could see a sense of people at that level, lower level, coming together to address whenever faced with a challenge. So it is true. And just to add more information on the earlier question on whether this is totally lost, no. Government has restructured it so. And now all the functions which were in COC2 have been put in the ministry in a division under Ministry of Agriculture. So we have hope that all these functions will still be maintained by the Assistant Commissioner and the research team that has been given that assignment to have continuity and address some of the key challenges of the silo nature which you have alluded to, and also strengthening the surveillance. So that's what I can give as of now. Thank you so much.
Thank you so much for that answer. I see a couple more questions. They're sort of grouped around a similar theme, which is the million-dollar question. How do you bring the ministries of human, animal, and environment, ecosystem health together? And I think, yeah, if we knew how to do that really well, we'd all be successful. But I wonder if any of the panelists that are on our call today would have something to share on that, how to bring the ministries that are so diverse in their mandates together.
Yeah, Lisa, I just can share to you that question. There are three important issues that really triggered us to really go for this collaboration, and I think it was understood at the higher level. Particularly when we had the cases of Nipah. Basically, Nipah is not a disease that you can solve alone in the human case, and that partnership developed between the public health and the environment, wildlife, and also other professional group of people. Second important point, when the avian influenza came up, we thought that we desperately need to work together, and we were casing, during around that time also, there are three other main cases. One is the anthrax. We had a very bad time in 2009 and 2010. There are a lot of anthrax cases, and those were also human cases. And those are those cases were mostly because of, eating, meat from the affected animal. And it was a red alert, government declared a sort of red alert. All those experiences, we really, it was a very difficult time for us, and strong advocacy from the One Health Bangladesh and also quadripartite and other development partner. They are also giving very strong voice. And that's how we were able to really convince at the higher level of the ministries. I would not say that is a perfect situation, but yeah, they are now. But when COVID came, I think it is more understood now that a collaboration at all level is very, very important. I have seen one question that, when you go to the down level, does it help you or not? Yes, it does, because, the reporting from the grassroots level is very important. When you talk about 717, if you do not get a report and right time, you cannot really go and go for outbreak investigation. If people are at the grassroots level are more sensitized, responsive, alert, then you can really go better way and solve the problem in a better way. And that is why I think coordination must go below, from national level to district, even to the UPOJL, or what we call, the lower level of the administration. And we have been
for sure.
strongly advocating it. People are accepting that appeal. Yeah.
Yeah. So there's another comment and question regarding institutionalization, and the comment says, at the EU level, the European Commission has a One Health unit under DG Sante. Do you think this is enough? Or does the institutionalization need to be even more top down and get more sectors under its umbrella? And I just open the floor up to any of our presenters who would like to comment on that. It's obviously what's your opinion? Do you think that that's enough?
Well, if I respond, I cannot say what is needed in the context of Europe. But as I mentioned earlier, if you want to really engage the people at the community level, at the different level, because they are the people who will really basically respond and practice One Health. National level directives is not always helpful. It does help you for compliance, but not necessarily changing the behavior, breaking the silos down to the block level is important. That's what is our experience. Maybe Europe is a different place, and they can give, someone from Europe can give a better response. Thank you.
Yeah. No, I think it's a difficult question. Does anyone else want to jump in with a short answer? Yeah, Abigail, please.
Sorry, I had a problem with my camera. I can answer from the US side that what you really see happening, a lot of the effective administration is taking place at state level and community level, and the platforms that are mostly engaged. I mean, the national level is also important, and there have been important things that have actually gone through Congress, but a lot of the real activity is happening at the state and the community level.
Mm-hmm. That's sort of related to, there's one more comment about the communication flow. How is that structured, within the sectors? And I think, again, it's quite context specific, but I wonder if any of our panelists have some insight into maybe ways that communication flow functions particularly well within the different sectors.
Well, for Bangladesh, we use the One Health Secretariat to communicate with the government different sectors, and they know each other very well. Any crisis, any emergencies that touch the One Health Secretariat, and in the One Health Secretariat, 3 group of people are working. People from the animal health, people also from 1 person from the animal health, 1 person from human health, and 1 person from the environment or for forestry. They are in the same seat. It is not a perfect one, but it is still better than what was a silo. Now they, at least 3 people can communicate with their direct department, and also they have their own way of working, communicating on different issues. There are some regular issues. There are some unusual issues. Say, for example, there is an outbreak, anthrax outbreak in one particular area, and then One Health Secretary take the lead to inform other agencies that go jointly. It is the joint activities that we need to take. So those are how we communicate. And
that's a good way to do it. Yeah, absolutely. And I know that in Ethiopia, for instance, in the Somali region, it's exactly the same. The surveillance and response team sits all together in the same office, and it's really quite efficient. Unfortunately, I'm going to have to close us off because we're short on time, and I want to give CABI the final word. So I want to just say a very big thank you to our 2 presenters and to the panelists, and as well for those of you who contributed questions. I hope we could get to most of them. We didn't talk a lot about financing, but maybe you'll check in on another webinar and we'll hit that topic because of course it's a really important one. So over to you, Georgina.
Yeah, thank you very much, everybody on the panel for joining us, and our speakers, especially Margaret and Nitish. It's been wonderful having you here. And as Lisa said, this is the first of two webinars looking at the OHHLEP cases, and we look forward to seeing everybody again at the second one. I think it's been a wonderful chance to talk about the cases and you know, to bring the practical aspects of One Health to life. So thank you all. This has been recorded, and you will be able to see it again from the One Health Knowledge Bank. So please take a look. And thank you again, Frida.
Yeah. Thank you all. There was so much engagement from the audience, so many questions, and I think we'll probably have to put our thinking caps on as to how we can probably see if we can address them in another format. But this is one of the wonderful thing about cases. They're very practical, and I guess that means they elicit those kind of questions about the practicalities and how to get down to that and how you can apply it to your own practice in whatever you're doing as well. Thank you so much, Lisa, for moderating so wonderfully and navigating the Q&A in such a wonderful way. And thank you to the speakers and the panelists who've joined. It's been wonderful. And there will be another one coming up. So please do stay tuned. Keep an eye out on our One Health Knowledge Bank page, because that's where we tend to have things. So yeah, do visit that, do explore it. We have lots of different things to explore on there. So thank you all, and I hope you have a wonderful.
Yeah, do you want to just pop the One Health Knowledge Bank? I didn't put that link into the chat, but I put the cases link in there, and I would just encourage anybody who's interested to sign up for the notifications when something new is published. You'll get notified, and other than that, just take a browse through now and again. There's a lot of good content, and there are also some cases on topics other than One Health. If you want to look through that, you might see what the other case compendiums look like. And yeah, thanks a lot for joining. You're invited to the webinar on methane, which is next week. Check out the CABI website, and otherwise we'll hope to see you at another OHHLEP One Health Cases webinar in the future. Thanks a lot.
Thank you, Lisa. Thank you very much. Thank you, everyone.
Yeah, thank you very much.
Thank you.